Welcome all. We're gonna just get started. Um, I am in Arusha, and so I'm reporting this at a coffee shop. So if I cut out, I apologize. I will try to join back in if I can with my phone. Um, so this is kind of part of a two-part series. We're going to talk a little bit about ultrasound, and how the machines work. I'll record it for anybody who wants to come, but the hope is that we can try and do a in-person lecture later this month. Um, and I will make sure that we try to kind of get something on the books, whether it be in Moshi or Arusha, hopefully in Arusha. I think most of you are based in Arusha. Um, okay, so let's talk a little bit about ultrasound. So point of care ultrasound implies that there is um, basically an ultrasound that's used by a clinician, not a formal exam. A good example of this is a case I had a couple of weeks ago, an individual who presented with hypothyroidism and had fatigue and weakness. When he presented, he seemed to have a euvolemic exam. His heart rate was normal, but he was hypotensive, and his extremities were cold, um, and his neuro exam was normal. He didn't have anything focal. With the hypothyroidism, there was a little bit of a differential, including cardiogenic shock, sepsis, hypovolemia, um, and the differential was kind of shifted according to the ultrasound findings. So we'll talk a little bit more about that and come back to that. So uh, basically, what we're going to be talking about is just talk about kind of what the applicability of point of care ultrasound is, and we're going to talk about how the machines work. We'll talk a little bit about the indications of the exams, and what kind of questions you can be asking and what kind of answers you should be looking for. We'll also talk a little bit about scenarios where ultrasound can be helpful. Um, Kind of basic objectives, but they're meant to be intentionally broad, mostly because ultrasound is an extremely broad topic. We're not going to be able to go all of it today, or even the next lecture. But the hope is to get an adequate introduction for you guys so that you guys can feel comfortable trying to incorporate it into your practice. Um, so usually the machines have three different probes. The probes include what's called the phase array probe, the curvilinear probe, and the flat low frequency probe. They're meant for each individual, like they're formulated and engineered for different examinations. The frequency basically implies the level of detail that you'll get, but also uh, assesses both movement and detail of the actual ultrasound. So when you use different frequency probes, you're going to get different pictures. So that's why they have different probes. So if you try to do a cardiac examination with a musculoskeletal or flat probe, you're not going to get a very good picture. And so it's important to know which each probe is used for. Um, the way that the machines work is that they shoot the ultrasound waves in through kind of like what I described as like a credit card distribution. And hopefully we can talk a little bit more about how that works when in the in-person lecture. Um, but the ultrasound's about structures. So the more dense something is, the more the ultrasound will actually receive the signal back. The one exception to this is that it can't go through air. Ultrasound isn't, the waves are too small to go through air. So air actually appears dense on an ultrasound. And we can talk a little bit about how that is on the pulmonary examinations. But in a broad sense, that's what's going on is that you're measuring density. And you're measuring usually the density of water. And since the body is basically formulated with water, excluding like the lungs and air within the bowel, usually you can see through tissues with ultrasound and examine certain parts of the body area. So I already kind of talked a little bit about this. Really what we're looking at is density. Density is what you're measuring usually with almost all cross-sectional imaging. MRI measures density, CT measures density, so does ultrasound, but they're just measuring it in different ways. Um, So I usually consider anything that I'm doing with the ultrasound machine as kind of an adjunct to my physical exam. In the United States, technically it's a procedure, and we can talk a little bit more about that. But it's billed as a procedure if you save images. Um, if I use it as kind of an adjunct to my physical exam, or I'm using it as a single thing, I want to know what answer to the question. I'm not just throwing it on any single. I usually only use it for certain cases and certain circumstances. The best example of that would be like a hypotensive patient. I really, really like it for differentiating shock patients, and we'll talk a lot about that. And then we'll also talk about like obstetrics indications for the ultrasound examinations. But really, the ultrasound is meant to answer just a single question. So the more focused the question is, the better. If you have a clinical question that I think this patient is sepsis, and that's why they're sick, then I usually use an ultrasound to try to confirm that and take a look at their kind of cardiac function and their volume status to make sure that I'm not missing anything else and to kind of guide to resuscitation. So the most common complaints I think that ultrasound is used for is hypotension. I'll also use it for individuals who are dyspneic. Um, Basically to try to evaluate both pulmonary and cardiac indices. There's a way to kind of incorporate this into your practice, and I can talk a little bit more about this as we get kind of into the cardiopulmonary section. It's very helpful for abdominal pain, especially obstetric abdominal pain, um, as well as evaluating hepatobiliary and aortic pathology. And the reason why emergency medicine doctors became kind of the the frontiers in terms of ultrasound management is because we used it for procedural guidance historically back in the 80s and 90s when these machines became more readily accessible. So I don't know if anybody has worked with me enough that they've seen me place an IV or do a thoracentesis with um, the ultrasound machines, but these are two things that I think could definitely be done in Tanzania, and two things that are practice changing as far as your practice goes. So when you talk about using the machines, there are a couple different things that you need to know. Again, I will send these lectures, and these lecture slides will be there for your um, reference, but you should know about gain and depth. Gain is basically the amount of brightness that shows up on the actual screen. Um, it's basically a concentration of how many waves you're sending and how much brightness you're having. The depth is basically how deep the ultrasound goes. The depth dictates kind of where your actual anatomical area of interest in the screen is in relation to what you're looking at. So if you're looking at the gallbladder, you want that centered within the screen, kind of hopefully within the middle of the screen. Um, and if you have too much depth or too little depth, you might not see what you're looking at adequately. So the other thing to know about these machines is the setting. The setting is basically dictated by each probe, and it is determining where the focus of the examination is in relation to the frequency. I did mention that each of the probes has a specific frequency. And so if you use a specific probe, each probe will have its list or subset of actual settings. And the setting will kind of help you determine what you're looking at. A good example of this is the abdominal probe has an abdomen setting, but it also has obstetric settings. And sometimes you can also use it for musculoskeletal examination. So the abdominal probe will in itself also have an MSK setting. So you want to make sure that your setting is appropriately chosen too. And we'll talk about that in person for sure. So I talked a little bit about the specific probes, and this would have been helpful kind of a little bit earlier, but this is the cardiac probe or phased array probe. We use this for heart examinations. It's the smaller probe. When you talk about the probe and its features, you're talking about the frequency, but you're also talking about the footprint. These probes are designed to kind of go between the ribs and look at the heart, look at the lungs. So that's usually what we use it for. The linear probe is usually used more for like musculoskeletal examination. It has a larger footprint and it's a higher frequency, so you get a little bit more detail, but it's much more sensitive to movement. So really, the only thing that we generally use this for is like for vascular studies and for musculoskeletal studies. The abdominal or the curvilinear probe is really used predominantly for um, abdominal examinations. You can use it for cardiac. I think that if there was one probe that I would focus on knowing how to use, it's the curvilinear probe. It's got a curved footprint and it's got a bigger footprint than the phased array probe. We do fast examinations with this. We do abdominal examinations. We do pelvic examinations with these machines or with these probes. And this is probably the most popular probe that we use. So I was talking a little bit about probes, but I also talked a little bit about gain and depth. Here's a good example of a study that is overgained, um, but has appropriate depth. So if you're looking at the gallbladder or you're looking at the IVC, which is right here, gallbladder is right here. And then you have the hepatic vein draining back in, or I'm sorry, the portal vein draining back into the IVC. You can tell that there's adequate depth because you can see all the structures. You can even see the diaphragm here. But there's too much gain. Transitioning over to this one, the gain is undergained, and you don't have enough gain because you can't quite see the structures. You can see where the gallbladder is, you can see the portal vein, you can see the IVC, you can even see the diaphragm, but you can't see the structures in enough detail. If you then transition to the bottom left, then you can tell that there's adequate gain, there's adequate depth. This is kind of exactly what you want the picture to look like. You want there to be bright features with kind of this, what we call echogenic appearance to the liver. And that'll give you the best picture and be the best for evaluating pathology. So um, moving on to one other last basic thing, orientation of the probe. The orientation of the probe dictates kind of where the probe is in relation to space, and will also be very important in terms of dictating your right and your left. So when you take a picture through a plane, you're taking a picture through either a transverse or a sagittal plane. You can also take what's called an oblique picture, and we can talk a little bit about that in person, but this is less common. Really, the most important views that you can get with an ultrasound probe are sagittal or transverse. So these are the ones that you want to know, and really kind of the most important. If you are taking pictures, if you're taking pictures of anatomy, trying to evaluate for pathology, the real important thing is to remember where your orientation is. Yeah. Um, and where the probe situates in space. An example of this is basically in most machines, there's a small little star where you can actually see where the probe is in relation to where you're touching. We'll talk a little bit more about this in the in-person lecture, but this is a common mistake for early learners. Commonly telling medical students and kind of people who I'm training these machines on to make sure that your orientation is appropriate. Basically what there is there's a little dot on the actual probe and you want to make sure that the dot aligns with the dot on the screen because then you're getting the actual orientation picture of right is right, left is left. It's hard to kind of explain over a lecture, but it's very easily understood once you actually see it in person. So this is kind of an important component to learning the skills with hands-on learning. Um, a little bit more about kind of this is more complex ultrasonography, but there are also dynamic measurements that we take, usually for vascular studies, but also for obstetrics and things like that. The three main ones are pulse wave Doppler, color Doppler, and M mode. M mode basically is this bottom right, and you're taking a still picture of a specific area within the actual ultrasound plane. So this is actually how ultrasound started when they were first invented. You have this entire picture that you have of a baby, and then you want to measure its heart rate. You draw a line through the actual ultrasound picture, and you can evaluate that point in space, and you can actually get a heart rate by measuring that point in space. That's called M mode. Probably the second most popular is color Doppler. This is basically where you're evaluating directional flow. So this is an oblique picture here in this top left, where they took a picture of it's probably the femoral artery and femoral vein, and they measured the directionality of the actual femoral artery. Basically, the general easy way to remember it is that this top left corner shows you direction. Red means it's coming towards you, blue means it's going away. This is much easier taught as in person, so we will go over this in person because color Doppler has kind of an effect in terms of examinations. The last one is less commonly used, but popular with cardiac, and that's pulse wave Doppler. That's this examination up here in the right upper quadrant of the slide. Basically, a pulse wave is a measurement of velocity, very simplistically. And it's commonly used for very kind of complex cardiac measurements. I do use it not infrequently. I use it during cardiac arrest sometimes as well. Or if somebody has a threatened limb, you can measure pulses this way. And you can get you can get monophasic, biphasic, or triphasic pulses from an examination. And that's actually something that I can convey to a vascular surgeon or an orthopedist if I was concerned about a limb-threatening injury. So that's pretty complicated stuff. That's kind of like ultrasound in a nutshell. That's kind of like the 101. I want to talk a little bit more though about actual indications for the examination and how it helps change management. Probably the oldest and the most probably well-known indication for ultrasound is the fast examination, right? So this was something that was actually created in the 80s to 90s when these machines started becoming more available. And we figured out pretty quickly that if you had an unstable trauma patient, you could do this bedside examination, and it could help with disposition. It's never actually shown to improve patient outcomes, but in the United States, it's become part of standard of care in order to appropriately disposition these patients. So if you have a hypotensive patient, it's very important to reiterate that they have to be hypotensive in order for there to be an indication for a fast examination. Um, and they're too unstable to transport to a CT scanner, then you want to do a fast examination. And if they have what's called a positive fast, meaning that they have free fluid in their abdomen or in their pericardial space, they usually would go to the operating room for further management. And if they had a quote unquote negative fast, they would remain in the emergency department for resuscitation, meaning that there was an immediate decision point in terms of is this patient having findings suggestive of hemorrhagic shock from an intra-abdominal bleeding, or is there potentially a different shock state? Do they have neurogenic shock? Do they have cardiogenic shock or distributive shock? Are they hypovolemic? Um, rather than rather than actually answering the question as to whether or not they're actually bleeding and that's what's causing their hypotension. Um, so this seems kind of like a no-brainer sometimes if somebody has blunt abdominal injury to the abdomen and they're hypotensive, it could be easy to attribute it to bleeding, but this is the easiest way to do so. I would say that this examination is the ultrasound examination that changes my management the most frequently is a fast examination. And then the second one is the rush exam that we'll talk after this. So how do you do a fast examination? Very briefly, you take it 4 pictures in 4 different quadrants. Remembering that pictures with ultrasound aren't just still pictures, they're dynamic pictures. And so you're trying to evaluate the area as much as possible, but also trying to keep in mind that if you have still pictures, a still picture is not necessarily worth as a video or like a fragment in terms of where the free fluid is. So usually with blunt trauma, I start in the right upper quadrant, and penetrating trauma, I start at the heart. Um, and you do all four in a specific order. It's meant to be very fast. I would say, that most ER doctors in the United States can probably do this between 30 and 60 seconds, and do it relatively quickly. Um, and it's meant to be done in a patient who is critically ill, who is usually unstable, and they're usually laying flat or supine. This actually becomes important because the blood in the belly is dependent. So if you have someone sit up, or if you have their head up, you're less likely to see blood in their actual abdomen, as opposed to if you have them lay supine or even in the Trendelenburg position, which is usually what I do for when I'm trying to evaluate for free fluid in the abdomen and I'm concerned about ectopic pregnancy. So here's a very quick examination. Usually in penetrating trauma, it's this guy goes first. In blunt trauma, it's this guy who goes first. You're getting four different pictures. Again, these are still pictures. I think these are still pictures. This is a good examination of the right upper quadrant. You're seeing the liver, you're seeing the kidney. Free fluid would accumulate right here. In the lower abdomen, free fluid would accumulate right here in the suprapubic area. This is four, this is two, this is three, and then this is one. In the left upper quadrant, fluid would accumulate right here, and the fluid would accumulate around the heart in the subxiphoid view. So a couple examinations, and kind of an exam finding of a positive fast. The free fluid is basically floating between the liver and the kidney in the right upper quadrant here. This is a concerning finding and would be considered a positive fast examination. So this plus hypotension would mean OR. You wouldn't allow this patient to go to CT. And I would argue that any general surgeon in Tanzania should probably accept this as part of their practice as well. So if you did this in a casualty or resusc area, they should be willing to take a patient who has a high pretest probability or high index of suspicion for intra-abdominal injury, as well as a positive fast and hemodynamic instability. In the left upper quadrant, the fluid accumulates a little bit differently. It accumulates underneath the spleen, between the spleen and the diaphragm, and that's just because of anatomy. But you'll get free fluid there. So it's very important to actually see the diaphragm when you're doing these examinations. When you're talking about free fluid in the pelvis, this is a lot of free fluid, but you can see that the bladder is outlined with kind of a hyperechoic area, the mucosa and the muscle. And then the free fluid actually accumulates around the bladder, inferior to the bladder, into the pelvis, anterior to the rectum. Usually, it's very important that you get two pictures of the suprapubic area, to make sure that it's actually free fluid, because sometimes the greater vessels can actually be confused. Um, in the examinations, when it comes to pericardial fluid, you can see the free fluid here. The dynamic picture here, though, is very, very important because you want to see what the heart is doing in relation to the free fluid. If the heart or the right ventricle is collapsing, kind of like it is in this picture, that's very concerning for cardiac tamponade. If somebody had a traumatic episode and they accumulated this amount of blood, it would be enough for them to get obstructive shock from the area. So usually the answer for that in the United States is actually a thoracotomy, which is way beyond the scope of this presentation, but something that a surgeon in Tanzania, depending on the resources, might consider. So that's a fast examination, kind of the second most popular and maybe my more favorite examination. It's the rush examination. This is basically an answer or a question about volume status. So if you have somebody who's hemodynamically stable or presents with hypotension, like the case intro that we had presented, these patients require kind of resuscitated measures and they can be incredibly stressful, but you want to make sure that you're doing the right things. You want to make sure that you're considering volume status as well as cardiac factors, and if the patient needs pressors or if they just need volume. So you're looking at a couple different things. You're looking at their heart function. You're looking at their inferior vena cava to assess their volume. And you're also looking for other pathology that might be present in order to actually determine um, why they might be hypotensive. I will say that generally this stuff is not nearly as important as these two things, which is usually my abbreviated rush exam. My abbreviated rush exam is, okay, what is their ejection fraction globally, and what is their volume status? What does the IVC look like? Um, it's a helpful examination when they put it against studies in terms of like gold standards of trying to evaluate for etiologies of shock. Um, when they put it against clinician judgment retrospectively, it's about 90% sensitive, 90% specific, but only when it's done completely and in the setting of someone who's a trained clinician, which I would argue most ER doctors in the United States are trained clinicians at this. I am certainly no expert at ultrasound, and I believe this to be kind of the gold standard in my view in terms of trying to evaluate why a patient might be hypotensive. So, really quickly, the first two things that I do here is usually actually start with the IVC, although that's not actually how they usually train it. They usually tell you to start with the heart. I start with the IVC because I want to answer the question very quickly, like, is it low, is it normal, or is it high? And the reason why is because the IVC will be kind of the most variable thing in each different type of shock state. In hypovolemia, the IVC will be low, which makes sense. The inferior vena cava carries, I think, about 70% of the blood flow back to the heart. The superior vena cava carries the rest of it. And so if the IVC is low, that indicates that the patient has low amounts of volume. And that they need volume resuscitation. The heart's response to that, though, will be basically hyperdynamic, and they're going to be tachycardic. Um, they're going to increase their heart rate, but they're also going to try to get the maximum amount of stroke volume per beat. So the hyperdynamic means that the heart is beating quickly and intensely in order to try to actually increase the cardiac output, because the stroke volume is down. Because of the volume. So if you correct the volume, hopefully the stroke volume increases and the body can compensate. When you talk a little bit about distributed shock, though, you're talking about somebody who has neurogenic shock or sepsis, and the IVC will usually be in a normal state, and the heart will also be hyperdynamic. You're talking about hyperdynamic here because of increased need for cardiac output. Distributed shock implies that there is capillary dilation, and so you need a higher compensatory cardiac output because of this. The distributed shock is more about the pipes than it is about the actual pump. So the heart has to start beating harder in order to meet the increased perceived demand from the body. So usually the answer for distributive shock is fluids, and then pressors, mostly because if their distributive shock is significant enough, you need to actually increase that vascular tone. Cardiogenic is a whole different ballgame. Usually the left ventricle will be diminished if they have cardiogenic shock, and that's just because it's a cardiac output issue. And the only way to actually improve that is to both increase the heart rate, but also increase the stroke volume. And usually the answer to do that is inotropy, chronotropy, i.e. pressors. So this is kind of the thing that's most helpful. The IVC is usually plethoric because these patients are either euvolemic or hypervolemic to begin with. And so the IVC kind of answers the initial question in terms of what their volume status is on presentation. You can hurt these patients with fluid. You can even hurt them with diuresis. Sometimes you want to keep them the same, but also just manage them with pressors and then try to control their lesion. Obviously, cardiogenic shock is very, very difficult to manage, has a poor prognosis. Um, but it also depends on kind of what the lesion is. Somebody has cardiogenic shock because of an old MI, then the prognosis can actually be pretty decent, especially if you can kind of control their acute decompensated heart failure and correct their hypotension with, a cardiac catheterization or a separate procedure in order to control their lesion. The last type of shock that you're evaluating for on these examinations is obstructive shock. Obstructive shock is just a vague term meaning that there is preload dependent shock, meaning that your right ventricle can't fill. This can happen from a pneumothorax. It can happen from cardiac tamponade. It can happen from severe asthma. There are a number of different reasons why you can get obstructive shock. Usually it implies, though, that the IVC will be plethoric and the RV is going to be diminished. So it's usually a volume responsive shock. Usually you start with fluids on these, but usually the obstructive shock, you require a couple different clinical pictures. And obstructive shock is something that actually needs to be mediated at the bedside, i.e. a chest tube, a pericardiocentesis, or, a thoracotomy or correction of the patient's underlying pulmonary pathology. So, like I said earlier, these examinations are really good when you're using them kind of in isolation. However, they should be used to guide the diagnosis and not definitively diagnose. You want to try to use your clinical judgment. I would argue that, if you're really good at ultrasound and you're a really good clinician, you will be able to fully differentiate all four shock states and kind of be able to guide where you're at. The problem is that if somebody is medically complex, sometimes they come in with mixed shock states and they're both septic, but they also have heart failure. Those patients can be difficult to truly diagnose. And this is where these examinations can actually be super helpful, is that you can assess their volume status and determine kind of where in the resuscitation you want to start. If you want to start with fluids and you want to do the full send of fluids and do 30 cc per kilo like we would do for sepsis, or if you're kind of concerned that you might tank them over and that they're a little bit less volume responsive than you would otherwise suspect, then you can start with a lower fluid bolus. But that's where the rush examination becomes so key in my mind, is that if you have a medically complex patient who is hypotensive, you can determine kind of where you want to start the resuscitation and where you want it to go. So this is an abbreviation of the rush examination. I'm going to circle the areas. These are the two important areas. You're taking a look at the IVC, which is taken kind of through this subxiphoid window, and then you're taking a peristernal long axis. All this other stuff is not necessarily very important. People who created the examination argue that you want to take a look at the aorta to make sure that it's not ruptured, make sure that there's no aortic dissection. You want to do a fast examination in order to try to make sure that they don't have any free fluid, that they don't have ectopic pregnancy, or that they didn't have a occult trauma, and that's the reason why that they're bleeding, or that they perfed their bowel. And then they also argue that you should do a pulmonary examination in order to determine if there's pneumothorax or if there's pulmonary edema. I don't usually do those things because I'm using the ultrasound in addition to my physical exam. If the patient has abdominal pain and they're hypotensive, then yeah, absolutely, I will take a look at the aorta, but I'm not going to take a look at the aorta in terms of every single septic patient who shows up to my emergency department. So really, the key parts of the examination are the heart and the IVC. That's a rush exam. So what does it mean when you're taking a look at the IVC? The IVC collapses like this, and you can kind of tell that the patient is taking a deep breath. When they take a deep breath, you can see the diaphragm is moving downward. In relation to the diaphragm moving downward, you can see the IVC is actually collapsing when the patient takes a deep breath, meaning that the heart is trying to send the volume back into the lung, and that their preload is low. So this means that their IVC is low and that they're hypovolemic, or that they're in a potentially like really late distributive shock state. So the answer to this is fluids. And that's usually kind of the simple understanding is, if the IVC is coming down, you are concerned that they're probably fluid down as well. The other alternative to this is, and I don't have a normal IVC in here for reference, but the IVC that is basically stagnant. It's not moving with inspiration or respiration. It's wide, and you can tell there's a very obvious difference between the left and the right. And this is an example of a plethoric or elevated IVC. This patient likely has either cardiogenic or obstructive shock if they're hypotensive, or they're extremely volume overload. You can also see, and this is just a very nuanced finding, they have some fluid in their lungs, and you can kind of see it behind the heart. You get a lot of information from that one picture. So um, in relation to the cardiac windows, this window is a good example of somebody who's hyperdynamic. You can see the mitral valve and kind of the middle portion of the screen right here is going up and hitting the septum. It looks like the patient is mildly tachycardic, if that. But this is a good examination of somebody who is hyperdynamic, as opposed to this picture on the very far right, where the mitral valve is not getting anywhere close to the septum, and is just trying to kind of beat away as fast as possible. These two examinations are, hopefully distinguishable between the two, and you can tell basically a lot from each of these individuals. The treatment for both of these individuals is extremely different based off their presenting symptoms. Even if they had the same symptoms, I would treat both of these patients very, very differently. I would give much less fluid to this individual on the right, and start presses quite a bit earlier than this patient in the middle. Same goes for each of these patients with the different IVCs. So that's why the rush is so important. And that's why I start with these two windows, is because you can gather a lot of information just by doing these two things. So in separation of the the rush examination implies that you're doing something for hypotension. There are ways of doing isolated cardiac examinations. I will say that I'm going to try to breeze through these next couple reasons for examination for time purposes, but also to try to kind of simplify things. I think if there are two things that I want you to take away from this lecture, is that the most important things that you can learn from an ultrasound examination is a fast exam and a rush exam. I will try to highlight on obstetrics, because I think that there's a good reason to learn how to do these things for obstetric purposes. We're going to talk a little bit about cardiac examination, but a lot of this is also nuance and kind of more in depth in terms of how it relates to emergency medicine, and specifically how it relates to emergency medicine in the United States. Okay, so if you're doing a full cardiac examination, you're taking four different windows. You're taking a peristernal long, a peristernal short, an apical, and a subxiphoid picture. Um, each of these windows gives you different amount of information, and they're all dynamic examinations. When you talk about ultrasound, you can have dynamic examinations or you can have static examinations. Static means that you're taking a still picture at one point in time and you're trying to diagnose something. A dynamic examination basically implies that you need the full information, you need the full picture in order to be able to actually make an evaluation. Peristernal lung were the pictures that I showed you previously in the rush exam. These pictures over here are peristernal lungs. Peristernal short, which I will have pictures of later, is basically flipping the probe 90 degrees, or 90 degrees in order to actually get a picture. An apical picture can be a tough picture to get, but it gives you all four chambers of the heart. It's really, really helpful for evaluating the right side of the heart and the left side of the heart in certain conditions. The subxiphoid picture, which is where we take the IVC pictures, really only gives you information about whether or not there's fluid around the heart. But the more important thing to know about that is that if you flip the probe 90 degrees, you can actually take a look at the right atrium, and connect it directly to the right atrium is IVC. And you can get a lot of information from the IVC. So what do we use these things for? You're using ultrasound to answer a question. What are my takeaways from cardiac examinations? Cardiac examinations are really kind of a hodgepodge. You could probably talk to several ER doctors in terms of when they're actually doing cardiac exams for patients in the emergency department. You'll get, ask 10 different ER doctors and you're going to get 10 different answers. Really, the reasons I do it is I want to make sure that they don't have pericardial effusion or cardiac tamponade. I want to evaluate them for heart failure, take a look at their left ejection fraction. I also take a look at their right-sided heart function if I'm concerned that they have signs of right-sided heart failure, or if they have underlying pulmonary disease and I'm concerned that they're developing porta pulmonale. I'll look at their right-sided heart. Um, but really, those are kind of like the two main things are, are they developing left-sided heart failure because of hypertensive heart disease or, a number of different other things or reasons why they develop heart failure. Methamphetamine is probably the most common reason in the United States that I see new heart failure in somebody who's otherwise young and healthy. Um, and then one of the other things that I've seen my partners do that I do less is ischemia, basically evaluations for wall motion abnormalities as relates to patients who have chest pain. I don't generally do that. I'm usually more using it as an evaluation for dyspnea. Do you have right-sided heart failure? Do you have left-sided heart failure? And is what I'm seeing correlating with my examination, or my examination, for whatever reason, kind of discerning the clinical findings that I'm getting. So here are quite a few pictures of different hearts and different planes. These are all normal. So the leftward is the peristernal long axis. This is basically an examination of the mitral valve. So what you're doing is you're getting the left ventricle ejection fraction from this. This is what cardiologists use in order to actually determine what the patient's EF is. So if you have echo reports that read out, what they're doing and what the patient's ejection fraction is, it's from these pictures. If you flip the probe 90 degrees, you can get a peristernal short axis. Don't worry about how these pictures are obtained. We'll try to actually go over this in the in-person lecture. Usually the peristernal short axis is where you're actually looking for wall motion abnormality. This is the left ventricle. The right ventricle is a little accordion in relation to it. You can see the right ventricle shape in relation to the left ventricle. But in reality, I think actually this is the better picture for actually evaluating the right ventricle as relation to the left ventricle. This is called the apical forechamber. You can tell why I feel that way because you can just see so much of the heart in this view. You're seeing the actual tricuspid valve right here. You're seeing the mitral valve here. You can evaluate for regurgitation if you're very good. You can also evaluate for, right-sided heart strain. You can also do something called a TAPSE, which is just basically a very fancy measurement of the right ventricle. And this is a good example of a good window where you could evaluate a patient for right ventricular heart failure if you had concerning signs or symptoms on examination or history. Subxiphoid window is the last one. Again, I think it's important to know that you can evaluate the IVC from this window. Really classically, what is happening here is that you're evaluating for a pericardial effusion. The reason why I actually picked this GIF in particular is that the clinician, whoever is doing this examination, actually fans through the picture, and you can see right here actually um, they see the IVC. So if you were able to flip the probe in that window, you'd be able to see where the IVC is, and you'd be able to see its shape, contour, and diameter, and kind of determine whether or not you are concerned about volume status. So um, that is the reason to get good at the xiphoid window. It's the IVC. But if there were cardiac windows that I would want you to be good at, it would be the peristernal long and the apical forechamber, because those are kind of the best pictures of the heart. This is a very dense slide. There are a number of different measurements that you can take in order to measure basically cardiac function. So this will give you a good estimate of what the left ventricle cardiac output is. This will give you a good example of the right ventricle cardiac output. We can talk about these in person if you'd like. Both of these give you good assessments of volume. Um, I am going to leave it at that. You should know that these are very clinically relevant examinations, but should only really be done by like a skilled ER clinician or a skilled cardiologist at the bedside. But if there was any reason that you wanted to get better at ultrasound, here are quite a few examples of why I think ultrasound is the bee's knees, because you can get dynamic measurements at the bedside. It's like being able to get an instant BMP or a metabolic panel. You can just basically get immediate examination of a critical finding, and basically get the the measurement that you're looking for. And it does change management if you know how to interpret it. So if you have a specific question that you feel like you can answer, these are good examples of things that can actually change management and can answer your question. This is all the different measurements that I was just talking about. This is called endpoint septal separation, or EPSS. Um, and this is what measures left-sided ejection fraction. You're basically doing a mode through the mitral valve, and then you're measuring how close the mitral valve comes to the septum. Again, we can do a little bit more of this in person, but this is kind of complex cardiac stuff. This is called a VTI. This is basically an assessment of how much stroke volume is coming out. You can do this uh, once when you initially evaluate the patient, and then give them a fluid bolus and see if their VTI goes up. If their VTI goes up, then they're usually fluid responsive. Um, these are a couple measurements of the IVC, and you can take dynamic measurements of it. Usually the most popular way is to shoot a mode through it and see how much it's actually moving with respiratory variation. You can see a good example here where a patient does not have any respiratory variation, as opposed to the one above it where there is significant respiratory variation. If you took an M mode of this exam and compared it to this exam, you would see very, very significant differences, and you could tell why it would give you information about volume status. Um, this last one up here is called a TAPSE. And it just basically is a measurement of right-sided ventricular function. Um, you're basically measuring how much the tricuspid valve moves in relation to the heart, and each heartbeat. A usual TAPSE will basically show like exactly what this is showing. This is an example of a normal TAPSE. The right ventricle is moving appropriately with each individual beat. That was cardiac. It was a very, very brief abbreviation of each of those things. And we can talk more about, cardiac examinations uh, during the in-person lecture. Home examinations can be as equally complex, but can also be simplified in a much more easier way. What I would usually say is that if you have weird chest x-ray findings that don't necessarily aren't explainable by collaboration of your physical exam and or objective findings, i.e. if somebody has what looks like a very bad pneumonia but doesn't have a white count, doesn't have hypoxia, doesn't have respiratory distress, doesn't have fever, doesn't have any of the other signs, symptoms of pneumonia. Usually what I would do is I would follow that up with a cardiac examination, but also a pulmonary examination of the area of interest. Um, the reason why is because you can see a couple different things when you do a pulmonary examination. Um, you can evaluate just a specific focal area, um, and in conjunction with auscultation, you can get a lot of different information. So, if you wanted to do a general pulmonary examination, you can evaluate 6 different areas. However, I don't really ever do that. I usually use it in the way that I just described. Positive chest X-ray with something that doesn't really make sense clinically. Um, so if I have a patient, I'll evaluate the focal area as opposed to using it as like a global examination. Um, the ultrasound will go through fluid, but it will not go through air like I talked about in the introduction. So if you wanted to look for where there's potentially fluid, you can see fluid in the pleural space. You can also see fluid in the parenchyma, which will create what's called curly B lines or pulmonary edema. The air will distort the ultrasound rays and create something called A lines. So if you see A lines instead of B lines, you're usually in the clear. Um, and basically, you can see the lung sliding in relation to the visceral and parietal pleura. Let me show you what I mean by that. So if you do a pulmonary examination, you throw the probe over the patient's intercostal space, you should be able to see this, which is just basically normal lung sliding. You're seeing the pleura slide against itself. You're not seeing any fluid underneath it. If you had enough depth, so if you increase the depth of this examination down, you'd be able to see what are called A lines, which are just these horizontal lines that go across the actual lung field, as opposed to B lines, which are these vertical lines that come up when you have fluid. Um, the B lines imply that there's some fluid within the alveoli or within the actual airspace. And it's what creates that consolidation effect. It's what actually creates that shadow, because you're seeing ultrasound wave actually travel through the lung because there's fluid within the lung. Now, if there's fluid between the actual, if there's fluid between the actual, um, sorry, my computer's low on battery. If there's fluid in between the actual pleura, you're going to see basically black fluid. And you're going to see the parietal and visceral pleura actually separate against each other. Um, while we're talking about uh, kind of point of care ultrasound, I do want to talk a little bit about abdominal exams. And how they relate to what we end up doing. Um, what I am going to do here, actually, just because I'm kind of concerned that my computer is going to run out, I am just going to breeze through real quickly. Here's some abdominal ultrasounds. Um, we're going to talk a little bit about pelvic ultrasounds as well. The more important thing is obstetrics, though. So let me talk real quickly. Usually, when I'm using point of care ultrasound, I'm evaluating a first trimester pregnancy. It's also helpful for you can get fetal heart tones in the second and third trimester pregnancies. You can also diagnose early pregnancies in the uterus as well as ectopic pregnancy. And if you don't see either of those, then you can also diagnose the patient with pregnancy of unknown location, which is a term we use commonly in the United States, might not be something that you guys commonly talk about in Tanzania. Um, this is a good example of an ectopic pregnancy. This is a good example of an IUP. Um, we can talk a little bit more about this in the in-person lecture. This would be a good, accurate representation of a pregnancy of unknown location because you can see what's called a gestational sac that can be present in all pregnancies, ectopic or IUPs, but it doesn't necessarily imply diagnostics. Um, there are also indications for testicular exams. MSK can also be made easier if you're good at ultrasound. You can evaluate fractures. It's actually better at evaluating rib fractures than it is than chest X-ray alone. And you can also evaluate for blood clots. So there are a lot of indications for ultrasound. You can also use it in cardiac arrest. You can use it for hepatobiliary conditions. Returning back to the case, the patient that I evaluated actually had cardiogenic shock, and to kind of reiterate how poor that prognosis is, cardiogenic shock does imply a very poor prognosis. The patient actually ended up deceased, but it did affect care. We started vasopressors and we limited the amount of fluid that we were able to actually give him. And it directly changed care just based off the ultrasound results. So in summary, ultrasound is awesome. It's a great adjunct to the physical exam. Um, you know, I think assessing volume status can be very difficult, especially when the patient has complex comorbidities. Ultrasound can help distinguish that, and can also evaluate shock states. Um, it's also good for a bunch of other different pathology. So, like I had mentioned multiple times, we're going to talk about this in person. The time is to be determined. I'm going to talk to Dr. Clement and figure out kind of when we can actually get get together. We're going to try and record it if we can. And we'll talk a little bit about how we can potentially do that for the people who aren't able to actually show up. One thing that I will give you guys in the next lecture is there's an additional resource in addition to what I'm going to post, and it's something called 5 Minute Sono. It's basically a ER doctor who created a bunch of videos. It's going to be more helpful to use this though after we do the in-person lecture. So sorry to cut this short. I fully intended to try to go as deep as I possibly could, but for time purposes and the fact I don't want to get cut off, I'm going to stop sharing my screen real quick, and I'm going to stop recording. And if you guys have any questions, um, hold them for just 1 second because I am going to answer them um, and hop back up on my phone. Okay, thank you all.